Professor Cranston is Professor of Medicine at St Thomas's Hospital Medical School. He is an honours graduate of Aberdeen who spent some years in the department of the Regius Professor of Medicine at the Radcliffe Infirmary, Oxford, before taking over the Department of Medicine at St Thomas's. He is known for many fundamental observations, amongst which is the study of fever, the subject of this lecture. Professor Cranston.
Fever has been a recognized accompaniment of infection for many centuries, but it's only in the last 20 years or so that we've begun to have some sort of understanding of the mechanism whereby it's brought about. It's true that in the middle of the last century, some German observers, notably Billroth and Weber, carried out experiments in which they injected pus from febrile animals into other animals, but the results of these experiments were extremely variable and contradictory.
This little instrument here is a clinical force dynamometer which we recently developed for use at Hammersmith on our patients complaining of muscle weakness and fatigue. You'll see here that it comprises a metal bellows. This is oil filled and it's connected to a pressure gauge, and then with this little dial on the upper surface of it, it's possible to see the maximum force that is generated in contact between the examiner's hand and the part of the body to which it is being applied. It's a very simple tool, but we found it useful in checking some of the results in clinical tests like this. Let me demonstrate how it's being used. The first thing to remember in using this is that it is the maximum force that is necessary to overcome a resisted movement on the part of the patient that is being recorded. So I'll ask the subject to hold the head up and then keep it there. Don't let me press it down. There we are. Thank you.
Let's begin by looking at the scene of the action. Here's a diagram of a nephron, of which each kidney has about 1 million. And arterial blood, skimmed very largely of its red cells and therefore predominantly arterial plasma, comes into this capillary tuft, which is the glomerulus, at a rate in the non-pregnant woman of something approaching ½ liter a minute. For the whole of pregnancy, that arterial plasma flow is raised by something like 1/2 to 750 to 800 milliliters a minute. And about 1/5 of it, 20%, is filtered from that tuft out into the capsule and down into the tubular system. In other words, in pregnancy, the glomerular filtration rate is about 150 milliliters a minute. Now, that's an easy figure to say, and a lot of people know it, but I think unless you visualize this, it's not very easy to know just what it involves. I'm going to empty a 20 milliliter syringe, which will take 8 seconds, into here. And that, as you can see and perhaps hear, is the glomerular filtration rate. And that is going on day and night, day after day, week after week. It's a great deal of fluid, and quite clearly the body cannot afford to throw away all that filtered plasma.
Asthma caused by extrinsic agents provides us with examples for the immunological analysis of allergic reactions in the bronchi.
The operation of the scanner differs from that of conventional X-ray equipment, but is essentially simple. The X-ray tube, which is continuously operating, requires a fairly lengthy warming up procedure, similar to that followed with X-ray therapy tubes. The patient's head must be correctly located in the machine, and for purposes of ease of calculation and accuracy, must be placed in the center of an exactly square perspex box, which is filled with water. This is achieved by forming the front face of the box with a rubber diaphragm, which can be drawn in to form a cap in the center of the box. When the patient's head is located in the box, the cap can then be allowed to shrink onto the patient's scalp, thus eliminating any air gap. A simple measuring device is then used to locate the correct level of the scan, and once the computer, X-ray control console, and scanning gantry have been correctly integrated, scanning sequence can begin. It takes about 5 minutes to complete, during which time the patient must remain perfectly still. Pictures of 2 contiguous slices are available approximately 20 seconds after the completion of the scan. A complete examination from base to vertex usually requires 4 complete scans, that is, 8 pictures.
Well, even though there is an individual susceptibility to obesity, we still have to recognize that these can be overwhelmed. And one's capacity to remain thin can be overwhelmed by social pressures, which we started the discussion with. Now here we have a strip cartoon to illustrate some of the points which one could make about the social pressures in our society which maximize our tendency to obesity. Take, first of all, our young friend Esme Fawcett, the young girl who's encouraged by her mother to eat a good solid breakfast. Now, there are 2 good points about this story. First of all, that she is in fact eating at a table, and that of course is becoming increasingly unusual, an unusual feature of the upbringing of children. The other thing is that she is in fact being encouraged to eat breakfast before school, but there are several things. One suspects that that young lad has a much better appreciation of the very high fat content of his typical British eggs and bacon, and in fact could well do without this form of force feeding. Esme, once she's consumed this breakfast, is anxious to get off to school, but the one thing that's not shown here is that her satchel is stuffed full of sweets and toffees and so on, as part of the mother's need to show her affection for her child. So off she goes to school with her sweets, which she can consume on her way, only to find that first prize in home economics goes to our young friend for producing her magnificent cake.
I'm assuming that most of the people who see this program will have already seen one by Dr. Philip James of the Dunn Nutrition Unit on the cause of obesity. So that to start, I'd like to recapitulate 3 of the key points which he made about obesity. First of all, it is convenient to define it as people who are more than 120% of the desirable weight for height, according to the experience of the life insurance companies. The prevalence is somewhere around 1 in 4 of all adults in this country, and the cause is always a positive energy balance. I would like to say something about prevention because, as you can see, treatment is often very difficult. Prevention is very difficult also because, for reasons that I mentioned before, it is not possible to forecast who is going to get fat. The energy imbalance which will produce obesity is very small compared with the range of individual variation. Therefore, what you can do in the way of increasing your chances of preventing obesity is to spot people who are moderately overweight and gaining and try and do something about it. I think that pregnancy is a time at which it is worthwhile being on guard against excessive weight gain. I'm not suggesting people should lose weight during pregnancy, but pregnancy is a time during which women are susceptible to dietary advice, and also it is possible to influence the advice that they will give to their children. I have said very little about the influence of exercise in the treatment of obesity, but I think that in prevention it is useful. People who regularly take a fair amount of exercise notice the disability, the decrease in exercise tolerance which overweight brings, and therefore I think that it has a disproportionately large value in preventing obesity.
Good day. Welcome to another edition of our research programs in obstetrics and gynecology. These programs, you remember, we're bringing from the University of London Audiovisual Centre in conjunction with the Blair Bell Research Society. In them we try and give you some background of a subject, and we talk about the current use of it, and we try occasionally to use our crystal balls, look a little into the future. And this program we're devoting to the subject of angiotensin and hypertension in pregnancy. We've asked a member of the Blair Bell Research Society, Dr. Fiona Broughton-Pipkin, who's the lecturer in reproductive physiology at the University of Nottingham, to come down and talk to us about this. Fiona.
Thank you very much, Geoffrey. Well, the very word angiotensin, which can be loosely translated as vessel tightener, gives some indication of what its function is. It's the most powerful naturally occurring vasoconstrictor substance yet isolated. It's 10 times more active on a molecule-for-molecule basis than is noradrenaline. It's produced by the action of an enzyme renin, which is primarily renal in origin, which acts on an alpha-2 globulin substrate in the plasma. Whether such a drug exists, I don't know. I think it might well be dangerous to try to interfere with the renin-angiotensin system as such, because I think that the high blood pressure may well be necessary for maintaining the baby's blood flow.
This would be some form of converting enzyme inhibitor, would it?
Yes, that's correct. Such an converting enzyme inhibitor is now available and is being very widely hailed as an extremely useful antihypertensive drug in the clinical trials which it has so far undergone. Its action is very dramatic. I have seen it myself, and it is fantastic.
This is on non-pregnant chronic hypertension.
However, is on non-pregnant chronic hypertensive patients. I would be very chary about giving it to pregnant patients.
And accepting your hypothesis, which I think I agree with, that the blood pressure is there for a reason, it would therefore diminish placental blood flow even further.
I think it might, yes.
But the first half of your desire experiment, to a small extent, goes on now, of course. Is there anything being done on people who've been induced to prostaglandins? I know you've only got 12, 18 hours after the prostaglandins have been given, but prostaglandins are being given, and the other group, of course, is the longer-term prostaglandin infusions for those having terminations of pregnancy.
Yes.
Anything there?
We are just starting to look at this. I don't really want to comment at the moment.
I'm sorry, I don't...
It was a habit of mine when I got up in the morning to make a cup of tea and to take my wife a cup of tea and a biscuit or a piece of cake upstairs. This particular morning I went to do the same thing. I went downstairs, I lit the fire, let the dog out. Then I should say, rather it was a dog who brought me round. He was licking my face, and I must have gone right out, because when I looked up at the clock, more than an hour had gone, and I didn't understand, and the kettle was boiling. Anyway, in the end, I made the tea and went upstairs and found my wife dead with blood all over her. And I looked, and I also noticed there was blood all over me.
You've just been watching a restaged interview with a patient of mine. It's a real patient, and the words of the interview are real, and we're going to call him Sam for the purposes of this program. But the part of the patient has been acted on this occasion to preserve confidentiality.